All right, hi, my name is Mallory Jansen, and this is my semester 2 case presentation. The patient that I'm presenting on, I saw back in November. He is a 64-year-old man who came in with complaints of cough. He said the cough has been going on for about 2 months. He was seen about 6 weeks prior to this visit and had been put on antibiotics, amoxicillin, and a course of steroids. He said that his symptoms improved for a few days after finishing the steroids and the antibiotics, but then the symptoms returned. In addition to what's written here, he did discuss that his initial um, 6 weeks prior when he was seen, he was having a lot more cold symptoms, congestion, um, and then more today, it was more just the cough and the cough that has been going on and not letting up for the past 6 weeks. He said his cough often sounds bark-like, or he has these coughing fits where he can't stop, he can't control the coughing. He denied fever. He says he may have had a fever, but he doesn't take his temperature. Um, he did say that he was having chills in his initial 8 weeks ago. Um, at that time, he was having chills, and he may have had a fever, but not today at this visit. He says his bouts of coughing occur randomly day and night. At night, the coughing wakes him up. Following the bouts of coughing, he has shortness of breath. Um, he has tried over-the-counter cough syrup, NyQuil, Dayquil, and Benadryl, but without much improvement. He states that he believes he is up to date on all his vaccines, including Tdap. Um, he does report that he gets frequent pneumonia infections, and the last one they had was about 2 years ago. So he is concerned about that, which is why he came in. His allergies, he says he only has seasonal allergies, no allergies to drugs. The medications he takes Lipitor 20 milligrams PO once daily at bedtime, Norvasc 10 milligrams PO daily, loratadine 10 milligrams PO daily. He doesn't take that year round, he just takes it during those seasonal times of symptoms. And then he takes a baby aspirin daily. His past medical history, he had chickenpox as a child. As an adult, he's been diagnosed with hypertension, hyperlipidemia, and seasonal allergies. And then in 1990, he had an appendectomy. His vaccinations, he has not had the flu vaccine this year. His last one was 2018. He had a pneumovax shot in 15, and he's unsure of his last tetanus shot. As far as health maintenance, his last colonoscopy was in 2016, and his last prostate exam was in 2018. Family history, his paternal grandfather had a stroke. His father had COPD. His mother and his father had high blood pressure. His paternal grandfather had heart disease, and his mother passed away from breast cancer. He's single. He was divorced 20 years ago. He has 2 grown children who are healthy and live nearby. He is a current smoker. He said he has smoked about a half a pack a day for the past 40 years. He states he would like to quit, but he's not ready at this time or at that visit. He said in the new year, that's one of his goals. He works full-time in an office for a construction company, and he is hoping to retire in 2 to 3 years. He denies alcohol or illicit drug use. On his review of systems, he was positive for fatigue. He states that the coughing bouts have really wore him out. But like I said earlier, he denies fever, Denies chills or night sweats currently. Said he did have chills when symptoms first began 8 weeks ago. Denies any skin issues. He wears glasses but denies any vision changes. Denies any hearing problems. Surprisingly, he denied rhinorrhea, sneezing, itching, or sore throat. Denied congestion. I would have thought that he would have some sort of symptoms like that, but he said nope, just basically the cough. Denies dyspnea and exertion, denies chest pain, palpitations or edema. Respiratory-wise, he was positive for unproductive cough and shortness of breath following the coughing bouts, but he denied no wheezing and no other real significant times of shortness of breath. He did mention at one point that sometimes walking through his house, he would develop shortness of breath, but he is attributing it to his current illness. He denies any changes in appetite or bowel changes, denies abdominal pain or indigestion, denies any swollen lymph nodes, and denies any muscle weakness. He just has the fatigue, and he states his abdominal muscles are sore from so much coughing. Neuro-wise, he denies any numbness or tingling anywhere. He does report he gets headaches following some of his coughing bouts. His vitals, he's 210 pounds, 6 feet. He did not have a fever today. His blood pressure was decent at 130/75. Pulse was normal at 76. Respirations were 20, and he was 96% on Grumere. On his physical exam, he is a pleasant 64-year-old Caucasian male who appears his stated age. Overall, he appears well-nourished, well-developed, and well-groomed. He wasn't in any significant distress at this time. You could tell that he was fatigued and tired, but he wasn't having any difficulty breathing or anything when I walked into the room. His skin was warm pink and appropriate for ethnicity. No rashes, lesions, cyanosis noted. His head was normal cephalic. Pupils were equal and round and reactive. His ears were fine. His tympanic membranes were fine. His conjunctiva were pink. His throat was just mildly red, but there was no drainage, and tonsils were normal with no exudate. And then he did not have any sinus pressure on palpation. Cardiovascular-wise, he had normal rate, regular rhythm, normal heart sounds, no murmurs heard. Respiratory, his rate just when he was sitting there was even, normal, unlabored. He did have a couple coughing bouts when I was in there, especially when I was listening to his lungs. That seems to always spark up coughing bouts in people. He would have the coughing bout, and we actually did hear that barking noise, kind of like a gasping noise, which I'll get to in a little bit, which kind of led us down the path of wondering about checking for pertussis. But anyway, following his coughing bouts, he was shortness of breath. He was a little bit tachypneic, but that resolved after a couple of minutes. The lung sounds were fine. They were a little dim in the bases, but other than that, they were clear. There was no wheezing, bronchi. They were not coarse. There was none of that, and no use of accessory muscles noted. His GI exam was normal, soft, non-distended. His bowel sounds were present. He was sore on his muscles and his abdomen when I was palpating, just from coughing, but no underlying pain in his organs, or you could tell it was definitely from just his muscles and coughing. His gait was steady. We didn't do a lot of strength checking, but he's able to move both bilateral extremities even, and he had good strength in them. He was learning oriented to place, time, person, and situation. No lymphadenopathy noted, and he had normal mood and behavior and speech, and thought content was normal. So this is where things were a little bit, I don't know, and I wasn't sure 100%. So ultimately, he was diagnosed with acute bronchitis, given the fact that he didn't have fever, his lung sounds were okay, his oxygen was fine. As I'll get to in a minute, we did check him for pertussis, and went treatment along that way, but ultimately even though it had been, and this is one of the things I wasn't 100% sure on, ultimately we did a bronchitis diagnosis. So some differential diagnoses, pertussis is definitely one of them. It is a respiratory infection that requires antibiotics. It starts with cold symptoms to begin with and a mild cough, and then develops into a high-pitched whoop sound, which is caused from the coughing bouts and then the kind of gasping for air at the end of that through the coughing bout. The coughing often leads to vomiting and exhaustion. And one thing I did not know until this was that these coughing fits can last for up to 10 weeks. Some other differential diagnoses, this patient may have asthma, with it's almost considered a chronic cough. People don't always have the wheezing with the asthma, so that is definitely one possible diagnoses. COPD is another one. This patient has been smoking for 40 years. He's 64 years old. He may be developing like the chronic bronchitis. And so that's one thing to think about as well. Pneumonia is another one that not so much likely, given the fact that he's not having the fevers, he's not having the tachycardia. You don't always hear wheezing or rhonchi or crackles with pneumonia, but it's definitely something to think about. If symptoms don't improve or if he develops a fever. Another differential is GERD, which is reflux into the esophagus. The patient denied any indigestion or heartburn, but long-lasting cough is a symptom of acid reflux. And some other options, he did have some sort of infection 8 weeks ago when he was seen. Most likely he could have a post-viral or post-infectious cough, which can linger for a long time after a virus or croup, but which is very rare in adults. But that barking cough is what would kind of make you consider that. So the plan for this patient, we did a nasopharyngeal culture swab that we sent off for pertussis, just to be sure that that we ruled that out. He was started on a Z-Pak. Actually, the treatment for pertussis is one of the primary first-line antibiotics is azithromycin. So if it does come back positive, then we'd already started treatment. He started on prednisone for 5 days to help with the cough and help with some of if there's any swelling or irritation in the airways. and then Tessalon pearls to help with the cough as well. So teaching, we educated the patient about the medications he was being prescribed, that azithromycin is also a first-line treatment for pertussis. So if he is positive for it, he had already started the treatment, and then we'll call him when the pertussis swab comes back. And pertussis is also very contagious, so we educated on the importance of starting the antibiotics and not being around real young babies, real young children who have not had a chance to be vaccinated against it. We reminded him to take all medications as prescribed. Symptom management as well. He can alternate Tylenol and ibuprofen for pain relief, for headaches or muscle pain from coughing or just general muscle soreness. He can take additional antihistamine, which he did try at Benadryl, if he starts developing congestion or postnasal drip, or it can help for allergies. He was on a allergy medication that he only takes as needed, so we encouraged him to start that back up. And then he could also get Flonase over the counter to help with the congestion, or if he is having inflammation from, if he does have something allergy related causing this problem, or asthma or something like that, that might help with his symptoms. We let him know if he develops a fever to come back to the clinic or his primary care physician. If the pertussis is negative and he does takes the medications and these symptoms still persist, we encourage him to make an appointment with his primary care physician to discuss other testing, like a chest x-ray or maybe a pulmonary function test to see if maybe he does have some of these chronic lung diseases. Also encouraged him to follow up with his PCP regarding Tdap shots. And then we educated him that smoking can cause these symptoms, and they can definitely exacerbate any illness that he has going on, making the cough last longer and the symptoms worse. We encouraged him to think about quitting smoking and let him know that there's education, counseling, and lots of help available if he decides that he's ready to quit. For a reflection, I chose this one for my respiratory case presentation. I felt like it had a wide range of differential diagnoses, especially given his long smoking history. There's many things that could be going on here. And his cough was definitely different. I don't know if I would say it was pertussis. I never did get to hear if that did come back positive or not, but that would be interesting to know. And then reflecting on this case, I go back and forth on deciding if I feel like he should have had if we should have ordered a chest x-ray for him. We didn't do one because he hadn't been having fevers, his oxygen saturation was fine, and his lung sounds didn't alert us to anything concerning that may be going on in his lungs. Definitely if these symptoms continue, chest x-ray would be a prudent thing to do. One thing I did struggle a lot with clinical is still knowing exactly when imaging should be ordered and when it shouldn't. Sometimes I feel like imaging was ordered when it didn't need to be, and then other times when I felt like it should be, that it wasn't. So, that's one thing I'm still learning. If anybody has any things that they learned or helpful tips, I definitely would want to hear that. And then my other question was, should Tdap have been given in the office that day? I know it can't hurt to give, and I tried to look it up to see if you shouldn't give it during an actual pertussis infection. I had trouble finding that answer, but that we didn't discuss that in clinical, but that definitely could be a contraindication. So overall, I feel like this case was a good learning experience, and I'd be interested to know how this patient ended up doing. And here are my references, and I want to thank you guys for watching my presentation, and have a great day.